It's my pleasure to welcome Samantha. She's a biomedical engineer, originally from Mexico, currently pursuing both the biomedical engineering PhD as well as the public health at Purdue University in Dr. Jackie Linnes' lab. She's motivated by healthcare inequity, and she focuses her work using equitable diagnostic for underserved communities through human-centered design. Her past work include a lot of point of care diagnostic ranging from COVID-19, Lyme disease, and PFOA detection in wastewater. Currently, she is developing hepatitis C diagnostic. And for those who didn't know, hepatitis C actually could link to liver cancer, which is one of the top liver cancer that we found in Texas. So the topic today is quite relevant to us here in Texas. Outside research, Samantha is also committed to youth empowerment, reducing gender disparity in STEM, and building supportive graduate student community that foster inclusion and collaborations. With that, welcome, Samantha. Please feel free to take it away.
Well, hello, everybody. My name is Samantha, and I'm really excited to be here with you all talking about how to bridge the gap in access in diagnostics, whether that's at the global scale or at the local scale. And so what we're going to be talking about today is like why this matters in the first place, what are some tools and strategies that we can use to address this issue, and then we're going to go into a practical example of how we can implement those strategies through talking about my project that is about hepatitis C diagnostics. And so why does this matter? Why do we want to bridge the gaps that currently exist in diagnostics access? This was some of the things and captions that I got from your readings. And what we saw and what we learned was that there's still very big inequalities towards access in diagnostic tests. I was impressed to learn that over half of the world still do not have access to the basic diagnostic tests. And so how can we achieve global health equity? Can we achieve that just by doing and focusing on developing new technologies and developing new diagnostic tests? What I was impressed to read, and I thought the articles that you guys read was very interesting, is that they were focusing and they were saying that the answer fully depends on how we define equity. And so here I wanted your input, and I wanted to hear about you and what your thoughts were. And so if you can scan the QR code, if not, I can also copy and paste this link into the chat. But this is just to hear about what, after doing the readings and after being in this field for a little bit, what do you think equity should be defined as in the biomedical field? And so let me see. Were you able to access it? I don't know if you can see it. Like, yeah. Is it okay, good. So when you start answering, we should start seeing here your answers. Yay, we got our first answer. Oh, I really like these. I really like understanding. I also really like awareness and solidarity. Accessible, mutually beneficial. Fairness. So we see that fair and awareness are repeated trends in how we define equity. Community, yeah, just balanced. Yeah, so I think we can get a pretty good picture and an idea of what equity should look like in terms of as biomedical engineers and how that is going to heavily impact whether and how we develop our technologies. Another caption that I read from one of the papers was that it doesn't matter if the diagnostic tools that we're developing, we're doing so with the best intentions, or if we're doing with like a lot of care and love for the communities that we're working for. If we're developing this technologies and techniques far from the point of views, fully like isolated in our labs, we can still fail to meet the user needs. Something that I learned throughout this past couple of years is that if we fail to meet the user needs, that's the best case scenario. Because if we continue to develop these diagnostic tools in isolation and then we put them out into the field, at the worst case scenario, we can further develop more health gaps and further increase this disparity that exists. So how can we address this problem, or how can we make sure that we're not participating or further enlarging the health gap that exists? So there's 4 tools that I wanted to talk about. The first one being contextual investigation. So contextual investigation is pretty much what it says. It's just observing the context of where our stakeholders engage and where our solution is going to be implemented. Because whenever we take a look at the broader picture, we can learn that there's different standards or like different factors that can affect the implementation of the technology that we're developing. So, for example, there's sociocultural factors that can affect whether a population or a community decide to implement the diagnostic tool that we develop. A very good example of this could be like self-sampling for HPV and cervical cancers. Some Hispanic communities are not willing to uptake this type of self-sampling methods because of what it involves or what it takes. So learning about what their social and cultural norms are is going to be very important whenever we want to design something for those communities. If we look at political or economical context, we need to consider what are the implications of the cost of a diagnostic test that we're designing, whether insurance companies are willing to uptake it, whether they need any type of certification, whether the diagnostic tool that we developed is cheaper than the alternative options and the ones that are already approved by healthcare systems or by insurance companies again. In terms of environmental context or local resources, we have to consider all of the things that are involved in our diagnostic test, right? Do we need continuous power supply? Do we need continuous access to water? Do we need stuff to be refrigerated? Because these are things that sometimes tend to be very given and very not thought of when we're designing things in the lab because we have them right there. But whenever we try to take our device into the field and we see that this is not the realities of where the implementation would take place, then a lot of the barriers arise. And same for like infrastructure, institutional, or processes and guidelines context or things that are happening around the implementation. So in my case or with my project, we're working with hepatitis C. I need to know exactly what the process is for getting tested and then integrated into care for me to have a better idea of how my diagnostic test needs to be. And so contextual investigation or contextual inquiry can be done in many different ways, but the most common ones are just by going into the community and observing the environment and what our users are, but also the processes that they go through, and also interviewing them. And so asking questions, why are they doing it? What is it that they do? And how is it that they get results? A second tool that we could use is called needs assessment. And this just means identifying the current gaps that exist and what is needed to solve them. This can also be done or like implemented through talking to their stakeholders, so conducting interviews. And something that I saw in the papers was that a need is a discrepancy or a gap between what currently is and what should be. And so this is something that we see a lot, especially in marginalized communities or low and middle income countries, that there's a lot of technologies that are trying to address the problems that they face. They're trying to address the gaps that they currently exist in the healthcare system. However, we don't see any change in the prevalence or in the conditions or in the rates or in the statistics in terms of like the epidemiology and the conditions. And that happens because of a lack of understanding of what it is that they really need in order to solve the problem. And so by filling those gaps, by talking to them and understanding how things need to be done, what things need to be done, where and why, we're going to be able to understand the needs that they really have in order to solve a problem that is real, rather than solving a problem that doesn't exist in the first place. Both of these strategies fall under the umbrella of what is called human-centered design. And human-centered design is a framework that focuses all of the design decisions that are happening in our development based on the needs and the desires of our users. And something that I really like about this framework is that it's based or it's the result of a process of empathy and fully understanding the activities, the environment, and the expectations of our users. And so the only difference between human-centered design and all the other strategies is that human-centered design really puts the stakeholder at the center of the entire design process. And it's done through very intentional and like open conversations It's done with empathy, and it's done in a cyclic way. It doesn't mean that we involve the stakeholder and we ask them questions and then we go into the lab and then we never talk to them again. It involves an open communication that goes back and forth throughout the entire design process. And so some of the key components of human-centered design is that it's based on the needs of the stakeholders. Like I mentioned, it's a cyclic process. And one of the main flagships of this framework is that we say that the stakeholders are the experts. They're the ones that they know their communities. They're the ones that know their needs. They're the ones that know and understand why current solutions don't work and how they could be fixed. And so something that I wanted to check in with you is, who are the stakeholders in the design process? Whether this is for your projects, whether that's for any engineering solution that we're developing, who are the people that we should be talking to? Who are the people that we should be considering in our design process? And I feel this answer should be shorter, so I don't think we're gonna have any issues when filling out this Menti. But let me open it up. Yeah. Can you see the Menti?
Yes, we can.
Beautiful. Okay, we have providers, key opinion leader, that's a good one, companies, engineers and users, patients, distributors, that's really good. The developing population is a repeated one. Yeah, so these are some of the stakeholders that we would, oh, humanitarian organizations, that's a really good one too. So yeah, whenever we're thinking about the stakeholders, another way that stakeholders is framed or worded in the literature is that we're talking about direct and indirect users. So people who would physically interact with the device and the technology that you're developing, but also people that are involved in the decision making about whether it gets implemented or not. So that's why I really liked some of the ones that said providers, right? They're the ones that are going to say whether they trust the diagnostic tool that you gave them, whether they're going to trust the result that they're providing. We also had, let's go back to it. We had humanitarian organizations. Some of the humanitarian organizations are the ones that provide funding or grants in order for some of these projects to be taking place and for the devices to be taken into whether that's marginalized communities or developing populations. So they also need to be on board with your design. In terms of the developers and distributors, is the stuff in the project that I'm designing feasible to even be taking place and commercialized? Because sometimes whenever we're in the lab, we make all these crazy decisions about whether the project can move forward and whether we can achieve whatever we want, but then we don't think about scalability and how we're going to make this replicable and how we're going to make this commercially available. Also talking about patients, are they willing to be able to use the device that you're designing? Is it something that they're willing to go through? Is it something that they're okay with using? Key opinion leaders, talking to the experts in the field, whether this is going to be solving a problem that exists in public health or whether this won't, whether this is going to bring more problems into the systems that currently exist. So yeah, these are all really good ones. And some of the stakeholders or some of the people that we don't consider sometimes or we don't think of as engineers can be insurance companies. It can be policymakers in government, because at the end of the day, they have to approve. It can also be certification organizations. For example, for diagnostic device, we have the CLIA waiver, and stuff like that. So thinking about all these things and all the different parts of the process and all the different parts of the design and the implementation, who is going to be playing a role on whether this actually happens and is approved or not. And so human-centered design allows us as engineers to go from thinking of the technology-based approach of whether this is possible and how we can achieve it, to starting with the human, to start with the patient, to start with the user. Is this something that they want in the first place? And so exploring what is it that they want, exploring what is it that they need, is going to allow us to get to a much better end result that is easier to be implemented and have a better outcome. And so, like I mentioned, this is a cyclic process. It goes by, or it starts by going out into the community and diverging and talking to the people and understanding their needs. And then taking all that knowledge that we gather and then converging and taking it back into the lab and start developing a solution, start working on something. And once we have a prototype, going back and diverging again into the community and working on a solution, working on getting their feedback. And then once we have their feedback, how do we implement it and make sure that the solution that we're designing is considering every single input that our users have? And so not only do we need to consider these things in terms of like the needs and the desires of our population, we also need to make sure that whatever we're designing is bridging the gap in healthcare. And so to do that, the World Health Organization set up a set of criteria that are called the assured criteria. That means that whatever diagnostic device is, it should focus on being affordable, sensitive, and specific. It also has to be user-friendly, rapid and robust, equipment-free in order to be simple to use, and it has to be able to be deliverable to the end users. Now, this criteria was designed and like developed back in 2006. And so it's been almost 20 years since that. And with the change of how the field has evolved, there has been a shift in the paradigm from going from assured to a reassured criteria. And that's just adding two more components, that is the real-time connectivity, but also ease of the specimen collection. Because if we think of our device and it's the simplest device that there exists, but then the collection of the specimen from the patient is extremely complex, then we're again introducing more barriers. So adding these two things is trying to make the entire process from sample to answer a lot more easier and feasible at the point of care. So we're gonna go over how these strategies play a role in like a project, and I'm gonna be talking how by implementing these strategies, we're addressing the hepatitis C disparities that exist among higher risk populations. And so like it was mentioned earlier, hepatitis C is a virus and it gets transmitted through blood-to-blood contact and it causes liver disease. When it's left untreated, it can progress into cirrhosis or liver cancer, and in worst cases, even death. One of the challenges with this condition is that it remains asymptomatic until it progresses into these chronic conditions. And although there's no vaccine for its prevention, the treatment options do have an over 95% cure rate. So they're highly effective. And still, we see that HCV is a major public health problem. Not only is it a problem worldwide with over 1.5 million new cases every year and about 300,000 avoidable deaths, it is also a major problem within the United States. And what we see is that there's a huge gap in prevalence between population, where people that don't have any drug use history have very low prevalence amongst them, but people that have a history of drug use or injection drug use, they have high prevalence within their population. So when we saw this gap or this disparity, we wanted to know why. And so we took a look at the literature, and what we saw was the testing guidelines that exist and that are recommended by the CDC. They make it challenging for a complete testing and then integration into care. And the reason for that to happen is that the testing process is a two-step process. And so it starts with an antibody test. And then if that comes back reactive, then the patient schedule up for a follow-up appointment to have a nucleic acid amplification test that basically detects the virus presence directly. And so when this multi-step process is implemented, only 64% of the patients complete both stages of the testing. However, when we go directly into the RNA testing, 95% of patients complete the testing and get integrated into care if needed. Another barrier that we saw is that for antibodies to develop in hepatitis C, it takes about 8 to 11 weeks. And so even if you go get tested, but you're within the range or that period where antibodies have not been formed, you're not going to know that you have an infection. And another highlight of RNA testing is that you can detect it within 1 or 2 weeks. And so there's that gap that we saw that doesn't allow for patients or doesn't allow us to determine whether there's a current or past infection by starting with the antibody test. It also involves a second appointment and a lot of other barriers that are introduced by implementing these guidelines. And so on top of doing our literature review, we also did a human-centered design. And so what we did first in order to go to the community and learn about their needs is that we did some contextual investigation and did some shadowing at health organizations that do HCV testing with a focus on people who use drugs communities, whether that was syringe exchange programs or other organizations. And one of the things that we learned is that the testers go to the population. So they go at syringe service programs or harm reduction organizations. They go and perform testing at parks and community events or recovery cafes and jails. And because of the nature of these environments and the places that they're at, they're only able to do an antibody point of care test. And if that comes back reactive, then they can't continue the process and they have to place a lab order for a nucleic acid amplification test. And the reason why they can't continue with the testing process is because the current options for what is called point of care detection of hepatitis C are on the subcategory of near point of care. And although they have high sensitivity and specificity, their running time is extremely high, and they're still benched up instruments that they require a minimal laboratory setup and continuous electricity. And as we saw, these are things that are not achievable in parks and these organizations. And so these can be implemented. And so our organizations are forced to then refer the patients for a follow-up appointment. Another thing that we did for our contextual investigation and needs finding is that we conducted interviews to some of our users. So we talked to the tester, to case managers, to training coordinators, program managers, but also to people who get tested. And some of the things that we learned was that a maximal time that our diagnostic test could take from sample to answer was 30 minutes. Anything more than that was not going to be feasible to be implemented because of the nature of the testing events and the environments in which they're at. But we also learned that our sample needed to be extremely low blood volumes because our population tends to be very dehydrated and malnourished. And so what we did from that contextual investigation and that needs finding is that we're implementing new design specifications. And so we set all these parameters and all these conditions that our diagnostic test needs to meet in order for it to be feasible and acceptable. And so from these ones, we decided to converge and go back into the lab and start designing our solution. And so what we decided was to integrate an amplification method called RT-LAMP with a lateral flow test for the true point of care detection of hepatitis C. And so RT-LAMP is a isothermal amplification method that basically what it does is that it grabs the RNA template or the HCV virus genetic material, and it basically copies and pastes it multiple times until we end up with many, many different copies. And so the reason why we chose RT-LAMP compared to PCR, that is the gold standard, is because by it being isothermal, it simplifies the equipment that we need to use. It's also a lot cheaper and it's a lot faster compared to PCR because it uses a little bit more primers than PCR. Now that can be one of the disadvantages because by using more primers, then we have the risk of amplifying other viruses, but this is something that we saw that the benefits outweighed the negatives. And the reason why we chose a lateral flow test is because it's simple, it does have a long shelf life, and it doesn't require any refrigeration. And although it has some negatives, like the volume and the viscosity of the sample can affect the result, and it's also a qualitative and binary result compared to a quantitative, the literature has shown that by combining RT-LAMP with a lateral flow test, you can get a sample to answer result within 40 minutes. And so we have developed something already in the lab and we have already tested it. And what we're able to see is a sample to answer within 45 minutes. And so what we're now working on is going back into the laboratory and working on more optimization for us to be able to take back into our stakeholders and complete that full cyclic process where we're going to be able to get their feedback from the device and the assay and the process, and then work on that final prototype for implementing in the community. So that's kind of what I've been working on. And I do want to thank my lab and everybody that has been part of the project and mentoring me throughout this entire process of learning how to work with the community and implementing that as an engineer.
Thank you so much.
Beautiful. Thank you.